Good afternoon, everyone. Welcome to today's webinar. My name is David. We'll be starting the webinar in about 5 minutes. I just want to confirm that everyone can hear my voice and hopefully you can see the video. So again, if you can hear me and everything sounds good, just type in that you can hear me. That way I know I don't need to adjust anything on my end. Okay, thanks very much and we'll see you very soon. Okay, I am back. Again, welcome to today's BioFlex monthly webinar entitled Laser Therapy for Temporomandibular Disorders and Tinnitus. And I've thrown in a couple other conditions as well. My name is David Kanashko. I'm a chiropractic director of education and training and a clinician here in Toronto at the BioFlex Rehabilitation Center in the west end of Toronto. Before we get started, I just want to do a little bit of housekeeping with respect to today's webinar. It will run about 20 minutes to 30 minutes depending on how the material flows. If you have any questions, please type them in as you have your question and I will address those questions at the end of the webinar. For any more information with respect to these and other webinars, please refer to our website, bioflexlasertherapy.com. We do host monthly training sessions in Toronto and remotely throughout North America. We do have a training certification seminar coming up in the first week of August. I believe it's August 5th and 6th in San Francisco, California. So if you're listening and you're close by and you want to attend or you just want to go out to visit California, please check out our website to sign up for that certification training. Okay, so let's get started. Today's topic, as I mentioned, is on temporomandibular disorders and seemingly related tinnitus. And I mentioned a few other conditions I'll talk about in and around the oral cavity. So I'm going to review, as I usually do, the physiological effects of low-level laser therapy, just so everyone can have an understanding of what our goal is when we're trying to treat these types of problems. Then I'll get into the temporomandibular joint, a very quick review of the muscles and the joint complex, and a bit of the pathology with respect to etiology and pathogenesis of TMD. Then I'll mention and review a randomized controlled trial. There's quite a few on temporomandibular disorders and low-level laser therapy. It's actually quite well researched, so I'll talk about one in particular. And then I'll talk about our approach, how we treat TMJ with BioFlex laser therapy. And then I'll go on to talk a bit about tinnitus, review its pathophysiology, and again, a randomized controlled trial on treating this condition, and then how we approach treating this condition. And lastly, I'll talk about a few other conditions around the orthodontic and dental world that you might come across, even though you're not a dentist. Okay, so let's get started. The physiological effects of laser therapy are many because it does tend to work on all cell types within the human body. So one of the interesting concepts about low-level laser therapy is its ability to induce angiogenesis and neovascularization over a period of time with treatment. This is important because as you increase the blood flow, you increase the tissue health. So with long-term use, your patients will experience an improved in function in part because of the increased blood flow on a permanent basis because of increased collateral circulation like capillaries, branches of capillaries, and new capillaries. One also well-known effect of laser therapy has to do with collagen production, critical in the formation of scar tissue and the healing of both muscular and tendinous ligamentous tissue in the body as well. So laser therapy is known to increase collagen production and increase the percentages of type 1 collagen, which is the mature, strong, tensile strength elastic collagen that's required for good physiological health. It also can help regenerate muscle tissue that's injured or damaged and also help with muscle atrophy. One of the most important things that laser therapy can do, especially in these conditions we're going to be talking about today, is reduction of inflammation and to some degree edema as well too. Inflammation by its action on circulating white blood cells like neutrophils, mast cells, macrophages and so forth. And by decreasing inflammation long term, you can obviously help with pain for your patient and also help overcome the inflammatory process and enhance these cells and tissues to start their healing process, or I should say to finish the healing process. So reducing inflammation around the area is critical in helping that tissue recover. And if there's any nerve regeneration or nerve injury, we can help nerves repair themselves to some degree, as well as cartilage production and bone formation, especially in cases of arthritic changes in the joint like the temporomandibular joint. So overall, you're looking at light therapy having an effect on many different cell types and tissue types. And as you'll see, most of these conditions are multifactorial, so it's not just one specific area that we're targeting to achieve relief. Let's review the muscular anatomy of the temporomandibular joint. The muscles that are easy to get to for laser therapy are the superficial muscles of the jaw and the face. For example, the temporalis muscle that of course helps with contraction and the biting of the TMJ, as well as the masseter muscle, the large muscle that connects from the zygomatic arch down to the inferior aspect of the mandible. And then we have muscles that lie intraorally for the most part, the lateral pterygoid and medial pterygoid. I mention these because they play an important role in the function of the TMJ. However, for laser therapy, unless you're able to treat intraorally in the very back of the mouth, we can't really access the pterygoid muscles with laser therapy. So bear this in mind when you're treating with our equipment, is you can't really treat the pterygoids because our probe isn't designed to treat intraorally. There are ways you can access the back of these muscles by going behind the jawline. So if here's the mandible line here, you can put the probe around the back of the mandible and you can irradiate to some degree the medial and lateral pterygoid, but they're much more accessible by opening the mouth and having a probe with a long extension to be able to contact those muscles more directly. Okay, so those are muscles typically involved in the temporomandibular joint. The TMJ, the actual joint itself, is a fairly complex articular synovial joint with a disc. This disc is oftentimes injured in whiplash scenarios where the jaw is displaced from the skull, causing tearing of the ligaments that hold the disc in place through arthritic changes as well. And you can see here the ligaments involved and the displacement of the disc as the condyle of the joint actually moves forward. Okay, I'm not going to go into any detail with respect to this joint. It's way too complex for me to do that in such a short time frame. But the purpose of me doing this is so you understand that we have to target both the muscles and typically the joint itself to be successful with treating temporomandibular disorders. Before I go on, I just wanted to check to make sure everyone can hear me. I know when I asked earlier, everyone said that they can hear me, which seems to be the case, so that's good. Okay. Generally speaking, they classify temporomandibular joint disorders into three different categories, although oftentimes they're mixed. There are a category under myofascial pain, so basically muscular problems due to the muscles that we just mentioned earlier. There's intercapsular problems where the symptoms tend to be clicking and locking of the joint because of disruption either of the ligaments or the disc itself. And very commonly, there's arthritic issues, osteoarthritis most commonly, rheumatoid arthritis can also affect the joint, even gouty arthritis can affect the temporomandibular joint. So when you're treating the patient, one needs to understand what the most involved component of the temporomandibular disorder is to focus the light on that area. Now when we treat, we usually treat both the muscles and the joints regardless. However, if there's more muscular involvement, then obviously we want to focus more on the muscles than the joint. And if there's just more joint involvement, then more of the joint. But most commonly, you'll be treating both of these specific structures. The etiology of temporomandibular disorder is multifactorial. One of the most common causes is bruxism, or grinding of the teeth. Oftentimes this occurs at nighttime when the patient's not aware of it. So there might be prescribed an intraoral device, a bruxism guard, by a dentist, and this usually does help a lot. So that is one common cause. Trauma, I mentioned, like whiplash, for example, where the flexion, extension, or acceleration, deceleration of the cervical spine and the skull are such that the mandible pulls away from the head. They each have different masses and acceleration, and it can actually tear muscle ligaments and the disc itself in severe whiplash. So it's very common for patients to develop TMJ or TMD weeks or months after the actual motor vehicle accident. So those of you who are treating MVA patients, make sure you screen the temporomandibular joint and make sure that you do follow-up questions about that, because oftentimes patients don't relate the temporomandibular joint pain with their whiplash. And it's important for that to be diagnosed and to be treated, and especially for insurance companies to be aware that there was damage to the joint, so that the patient might need to be referred to a dentist for perhaps a guard, mouth guard, or other treatment as well too. Repetitive stress, like constant chewing of gum and stress where you're clenching a bit of your teeth as well. That's another common cause of temporomandibular joint disorder. Myofascial pain syndromes like trigger point syndromes, those kinds of things. Fibromyalgia, they can also be sometimes linked to stress and oftentimes cause pain in and around the temporomandibular joint. And of course, as I mentioned, the arthritides like OA and RA are fairly common causes. Symptom-wise, well, obviously you'd expect pain in the joint of the TMJ, and most commonly the pain is in the anterior, so anterior to the joint is where the patients usually feel the pain, but it can be all around the joint as well, including the posterior aspect and into the external auditory meatus. Jaw movements are oftentimes reduced, so you need to check the range of motion of the jaw. The most commonly accepted range of motion normal is putting two fingers together, two knuckles together, and allowing that to be able to, when you open your mouth, those two fingers to be able to enter between your teeth. Clicking or similar noises of the TMJ are also common to this problem. However, it has to be linked to other symptoms. In other words, if a patient just has some clicking or noises out of their jaw but no pain, it's not considered a temporomandibular disorder. So you do have to have other symptoms to be linked to temporomandibular disorder. Oftentimes patients have headaches. That would make sense because of temporalis involvement and referral due to trigger points. And what is really interesting, and especially relevant to today's webinar, is the fact that TMD is also oftentimes associated with tinnitus and sensitivity to sound and even vertigo. So it's actually sometimes common that the patient's tinnitus might be in fact related to the TMJ. So one has to look at that as well if you're treating a TMJ and ask about any issues with their hearing, any issues with hearing noises as well, to be assured that that may also be part of the whole complex. There is a muscle pain cycle. It really initially starts by the actual trauma to the area, even psychological like stress, could be metabolic or these other causes that I've talked about earlier. And this will cause constant contraction of the muscle tissue, which leads to poor blood supply. So in other words, there's accumulation of metabolites, less oxygen. So right away you can see if you were to treat the muscle tissue with laser therapy, this would help increase oxygenation, both through the short term through release of nitric oxide and causing vasodilation, but also long term by helping with capillary network throughout the muscle tissue. And with prolonged constricted blood supply, it leads to chemical changes in the muscle. For example, we're talking about inflammatory mediators like interleukins, certain interleukins and cytokines. And then this of course, long-term starts to cause muscle soreness, even spasm of the muscles involved, and of course leading to long-term chronic pain. So it's very common that patients that have TMD have chronic pain in and around their jaw and headaches and so forth. It's actually a fairly common problem and one that many patients oftentimes will mention to their dentist, and it would be a good referral source for you to meet your dentist in the local area, bring some literature. If you'd like any extra research or what have you, please email me and have them get to know you with respect to your ability to treat TMD and also the evidence behind it. And you may in fact find a really good referral source through your local dentist, especially if you have to self-refer back to them for your own patients that might need dental care related to TMJ disorders as well. Okay, so that's a commonly known muscle pain cycle. And I mentioned there's actually quite a few papers. I can't remember the exact number, but I'm sure it's over 20 to maybe even 30 randomized controlled trials and other papers out there. This one was done on low-level laser therapy on obviously TMD, and they looked at 45 subjects. You can see the breakdown of ages in female and male. They all had presenting signs and symptoms associated with chronic TMD, in this case over 6 months. And you can see the wavelength they used, infrared, and the power, 70 milliwatts. Okay. These patients were randomly divided into 3 groups such that one subset had a much higher dose, and you can see the dosages there, 52.5, and then they doubled that to 105 joules per centimeter squared, and the third group was placebo laser, so no light at all. It was double-blinded model, so the patient and the investigator didn't know if they were using the laser or not, and the patient didn't know if they were receiving the laser or not. This is how they approached treatment. They used just a laser probe, and you can see they treated around the condyle. So if this round circle represents the condyle of the mandible, they treated anteriorly, posteriorly, superiorly, and inferiorly around that condyle to get around that joint. They also treated directly into the external auditory meatus, hoping to get the posterior aspect of the joint as well. And you can see they also did points. It's not really clearly shown here, but these points are for the masseter muscle, so they treated that as well. So this is the results they found, that they found there's an increase in mandibular range of motion. So when they tested pre and post treatment, the range of motion had improved, and there were less pain during the symptoms, less painful symptoms during the assessments and follow-up. They noticed the greatest change was in the patients that received the highest dosage at 105 joules, especially in the early and the first assessments. This is really notable because as you really increase the power, you actually have a stronger analgesic effect. So this may be related more to the analgesic effect as opposed to the anti-inflammatory and healing effect. That's because G1, the lower group, also had improvement in symptoms. However, they came on a little bit more slowly and gradually, which makes sense because G1, or the first group with a lower amount of dosage, was geared more towards photobiomodulation and healing of the disorder, as opposed to G2, where they're focused more on a much higher level of light to kind of block the pain in a temporary fashion. Okay, so bear in mind there are two different approaches for this paper. So the higher doses may promote remission of the painful symptoms, again, as I mentioned, due to its analgesic effect. However, the lower doses have a greater effect on the anti-inflammatory effect, and therefore have a secondary analgesic effect as time goes on. Okay, so when you're treating TMD, be aware that we're using more lower doses, and we're geared towards having a secondary analgesic effect as you start to treat. So in other words, after 2 or 3 or 4 sessions is when the patient starts to really notice a much higher analgesic effect due to the decrease in inflammation. Okay, this is our approach to treating TMD. This is from our manual. And A and C are referring to the placements of the array. So you can see the array, the first placement under A is geared towards treating the over the joint itself, even a little bit higher into the temporalis muscle, and the posterior aspect of the joint and over the external auditory meatus. The second placement is more to get into the masseter muscle, so it's shifted forward and at an angle parallel to the lower level of the mandible. And then the points are typically done in and around the external auditory meatus, the joint itself, and the muscles, and I'll mention those in a second. So let's just review. For the laser probe portion, we're going to treat the external auditory meatus, and we're going to treat around the joint itself. So similar to the previous research, we're going to treat posterior, anterior, superior, and inferior around the joint complex, around the condyle. And you're going to use a laser probe to treat the affected muscles that you can get at. So for example, the 3 portions of the temporalis muscle and the superior, middle, and inferior fibers of the masseter muscle. And I mentioned to treat the pterygoids intraorally, you can't really do that with our equipment. However, I didn't show it here, but you can actually treat behind the mandible and push the probe in, and that you will be able to get some of the masseter if you use the infrared, or some of the pterygoids if you use the infrared probe in that position as well. Okay, so our protocols, you can see, are fairly low. The red array is continuous wave, anywhere from 6 to 8 minutes. We tend to use a lower number of minutes if it's an acute scenario. We start off with 10 hertz and 40% duty cycle. You can see that it's fairly low, okay? And we can gradually increase that to within stage 1 up to 20 to 70. And the LDI 200, probably anywhere from 4 to 6 minutes is adequate to treat the muscles involved in the joint. And then you can see the progression where we start to modulate the red light, increase the duty cycle as well. And then By stage 3, if necessary, we're really increasing the frequency quite substantially to help overcome plateaus as the patient's being treated. So those are the 3 stages for a treatment of TMD. Some treatment tips that Dr. Khan has talked about in his manual is that, as I mentioned, for acute conditions, you can actually either decrease the treatment time, so instead of 8 minutes down to 6 minutes, and then start to increase that time as the patient is over that acute phase. Okay, you can also start to modulate early as well too, and don't forget to set the laser probe to 40% power, or even lower than that if it's a really acute scenario. Okay, and you can increase that probe up to 100% as a patient tolerates and as you're overcoming plateaus or the patient isn't responding as well to the 40%. We actually have really good success with TMJ disorders. I've been treating them for quite a while now, and it's a really easy treatment. As far as the array goes, usually we have the patient hold the array. So if I'm going to switch back here and just show you, let me see here. So the patient actually puts their hand over the array and holds it there for the treatment. And you can support their arm with a pillow if you want. Another alternative is a patient lying on their side on a pillow and just lie the array over top the joint as well. However the patient is most comfortable, you can do it any way that you'd like. Okay, let's talk about tinnitus. And tinnitus is a really interesting condition. We tend to get a fair number of patients that have a complaint of tinnitus. And there's 2 types, objective and subjective. Objective is a fairly rare form. It's actually sound generated somewhere in the body and it reaches the ear. So for example, turbulent blood flow, even contractions of muscles in the middle ear like tensor tympani can cause objective tinnitus. Fairly rare condition and one that we don't normally come across. So I'm going to focus more on subjective tinnitus, which is not associated with a physical noise, but is only audible to the affected individuals. In other words, if I take my stethoscope, I can't hear any noise, whereas a patient can. Okay, there's different types of pathophysiological processes that may cause tinnitus. For example, the most common cause is actually due to the inner ear itself. For example, due to noise-induced hearing loss in musicians and so forth. Presbycusis, sorry, it's a hard one to say, which is just age-related hearing loss, otosclerosis, kind of like bone spurring of the bones, 3 bones of the middle ear, infections, impaction of earwax, Meniere's disease, and so forth. Less common are neurological issues related to head injuries or whiplash, even multiple sclerosis, other types of nerve-related disorders, and tumors as well. So you have to be careful and make sure that these more serious conditions like tumors and MS and so forth are ruled out because that makes it really important when you're treating these patients. Some other causes are infectious. As I mentioned, things like otitis media, Lyme disease, meningitis, and syphilis can all cause tinnitus. And drug-related issues secondary to taking NSAIDs even, certain types of antibiotics, certain types of diuretics, and chemotherapy agents. Chemotherapy, I've seen that quite frequently as side effects of tinnitus in these patients as well. So again, all of these have the potential to cause this type of condition. Now, I have to admit, the research for tinnitus is not huge. There are quite a few papers, but not nearly as many as TMD. And the results are not as favorable with respect to the consensus. There are quite a few positive papers, but there's also some negative papers as well. The negative papers really seem to use too low of a dosage, in my humble opinion. So I'm not surprised that the results were pretty sketchy. I did choose this one paper that used a bit higher dosages, which is what I'd like to see. This paper looked at chronic tinnitus, that is over 6 months of duration in 35 patients. They used a combination of different wavelengths from red all the way up to infrared. And they used a fiber optic laser in a device where it entered the external auditory meatus, and from that fiber optic they were able to induce different wavelengths into the ear. They treated over 2 weeks, 5 sessions is how they approached it. And you can see in the lower right through the diagram or the photograph of the apparatus, the experimental apparatus. So they were able to quantify the tinnitus with respect to self-assessment, that is the loudness, the frequency, the amount of annoyance by the tinnitus, and also they did audiometric assessment as well, so subjective and objective measurements. And here are the results. So you can see after the last treatment it was measured, or they did follow-ups at 1 week, 4 weeks, and 6 months. And they found that 18 of the 35 subjects had attenuated tinnitus, that is, it lessened in severity to different degrees. And what was interesting is 6 months later, 13 of those 18 subjects still had less tinnitus than at the very end of the treatment session. So a 6-month follow-up was quite good. And then you can see 2 clients actually had complete cessation or disappearance of their tinnitus. And then you can see there's a subset of groups that had unchanged symptoms, and a few that reported increased. However, by the 6-month follow-up, that increase had disappeared, so it wasn't a permanent side effect of the treatment. Then they looked at audiometric assessment, and they found that of the 35, 9 people had objective tinnitus lessening, and again that continued over the 6-month follow-up. And same thing for the disappearance group and the unchanged group. You can see that they started to actually have more and more tinnitus. So you know, obviously it wasn't overly helpful, the control, and the increased subset by the 4 weeks was no longer the case. So again, it makes a good case to show here that it may very well be helpful, but remember that tinnitus is a very challenging condition to treat. You need to be patient with it, and the patients need to understand that you know, it's not one of these traditional treatments that we do. So you know, it's hard to say give a specific prognosis or a specific time frame as to how long it might take. Generally, we treat 6 to 12 visits, with 12 being more of the norm. The treatment's pretty similar to TMJ, except that what we're trying to do here is we're going to almost do 2 treatments around the external auditory meatus and around the mastoid process and around the temporal bone. The idea there is to irradiate as much of the bone and the external auditory meatus as possible to have an impact of the blood flowing into the inner ear. And we'll also do laser points as well, and I'll talk about that very shortly. The protocol is slightly different than TMJ. It can either be in stage 1 a continuous wave, or if it's a very severe tinnitus, you can modulate the red light at the very beginning at 10 hertz, 50% duty cycle. You can see the treatment times are a little bit longer, 8 minutes and 10 minutes for the infrared. The infrared array is set at 1040, fairly low again. And the LDI 200, 5 to 8 minutes depending on the amount of area they need to treat. And then you can of course see stage 2 and stage 3 increasing frequency and increasing duty cycle as the patient plateaus. Some treatment tips: always be careful to protect your eyes. That's a no-brainer, I would think. I talked about the positioning of the arrays for tinnitus. Try to make sure the probe is directed away from the eye during treatment. If you have the red probe, it's also very helpful in these cases. And again, set the laser probe to 40% of power as opposed to 100%. Okay, just so you can understand some anatomy here. Schematically, here's the external auditory meatus. Here's the tympanic membrane. There are the 3 ossicle bones, and then you have the inner ear within the temporal bone. In relation to the mastoid area, okay, behind the ear. So if you're trying to access the inner ear through the bone, you have to treat around the mastoid and above and behind the mastoid and to try and get some light into the temporal bone to affect the actual inner ear. So here's a schema or a picture of the skull, and we're trying to do points around the mastoid, behind the mastoid, superior to it, and around the external auditory meatus. And we can also, and you should, be using the probe directly into the external auditory meatus to try to get light directly into the tympanic membrane, or through the tympanic membrane and into the middle ear and into the inner ear. Okay, so it's challenging, it's difficult. That's why these conditions tend to be a little tricky to respond, but that would be the protocol on how to do that. I know we're running out of time. Boy, it goes by fast. Some other conditions, I thought this was interesting. Oftentimes in the dental world, they use separators between molars in preparation for braces. And these separators are usually rubber bands. Sometimes they're pieces of metal. And usually in children, and they're usually really painful. The kids are always given anti-inflammatories and pain medication. They've done a fair amount of research on this and found that laser therapy was very beneficial. So they did a meta-analysis of 6 studies, and compared to the placebo group, they found that laser therapy has a good analgesic effect at both 6 hours, 1 day, 2 days, and 3 days after the placement of the separators, which is really found to be statistically significant. Less statistically significant, but still positive, was at 2 hours, 4 days, and 5 days. So they concluded that that laser therapy can reduce pain caused by the placement of these separators effectively. So if you have patients that have children that are having this procedure done, have them come in, place the array parallel over the teeth on the cheek. Just one placement is usually fine on either side over the affected area, and then you can also use the probe over the molars that are affected to help with the pain. Lastly, I wanted to mention about the treatment of post-molar extraction. This was a crossover trial involving 22 healthy patients averaging older than 17 years of age, and they had either a partial or full bony impacted mandibular third molar extraction. So you can see the picture of the molar being extracted here. They treated both intraorally and extraorally, and they used infrared light, 780 wavelength, 10 milliwatts of power, and they concluded that the patients that were treated with laser therapy experienced larger clinical reductions in the intensities of pain, swelling, and muscle spasm at 48 hours and 7 days post-op. So I bring this up because although we can't do intraoral work, you can treat overlying the post-molar extraction area, and we've done this quite a few times here at the clinic, and it's very effective. So again, it gives patients an option, especially ones that are sensitive to medications or want to avoid medication, some pain relief. All right, that's all our time today. Please email me if you have any questions, and I'm just going to quickly pull out the questions right now and see if you had any questions. All right, so I see a question here. Can vision problem be associated with facial pain, Haroon? I think that could be part of the complex for sure. Sometimes even related to certain types of headaches, people have visual disturbances, but that whole complex one needs to be very careful about and make sure proper neurological assessment's done. But it's not uncommon to have issues with vision as well, and the patient should be properly assessed. See another one from Evelyn, who has a client who claims he stopped chewing gum and his neck pain was significantly reduced in the last week as he gave it up. Could that be a correlation? Yeah, I think so, because Evelyn, with respect to chewing gum, you're also engaging stabilizing muscles around the jaw and the neck, so that would make sense. Is this treatment successful for traumatic brain injury? Well, we approach TBIs a little bit differently. We're approaching more the cervical spine region and the suboccipital region, the base of the brainstem as well, and sometimes even over the cerebral hemispheres. So I would say that for the protocols I've talked about today wouldn't be specific for that specific type of problem. Okay, I am taking a break in August from webinars, going on vacation, and we will resume in September for our fall series. Once again, please email me if you have any specific topics or subjects you'd like to hear about, and I will put up the new series coming up in the next 2 or 3 weeks. Thanks again for attending, and we'll see you all in September. Don't forget about coming to our certification trainings if you haven't already in Toronto here every week. Check our website for that, and coming up in San Francisco August 5th and 6th. Check out our website at bioflexlaser.com. Thanks very much and have a nice day.